Welcome to Healthcare IT Today. I'm John Lynn, together with special guest host Dr. Colin Bannis from Dr. First. The world of technology and healthcare ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be talking about optimizing the medication journey from prescribing to adherence to improved outcomes. And today's episode is sponsored by Dr. First, optimizing medication management from prescribing to adherence. Discover how EHR and HIT vendors can streamline clinical workflows, improve patient care, and enhance overall satisfaction and efficiency for their clients at drfirst.com. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Bannis. Plus, check out our 18 years of health IT content at healthcareittoday.com. Welcome, Colin. Excited that you were able to make the time. You travel, I think, more than I do to conferences. That's amazing.
Hey, John. It's probably a tie, but yeah, I got in late last night. I was with our friends from Athena. They had their big conference yesterday during
Wow.
the week. But yeah, we cross paths constantly.
Yeah, well, I don't think that's an award either of us wants to win. We're probably happy to be home, but it's great to have you on the program. I love having these podcast takeovers with a special guest host. It's awesome. But today's topic is an important one. I think medication management's getting more and more complex. So, what would you say it takes to really do medication management well now?
Yeah, there's a lot that goes into it. I think the most important thing, I think a lot of people will say data.
Mm,
You can't measure, you can't manage what you can't measure. I would argue it's actually information. So, data becomes information, becomes
yeah.
insights, et cetera.
Makes sense.
I think information is probably the most vital piece of medication management, and making sure that that information is complete and it is usable and it is accurate. And then once you have that foundation of data, then you can start to do really wonderful things in this realm of medication management.
I mean, it's interesting you talk about data versus information because I kind of look at it and say, man, medication management is hard because the data is all over the place. One person has, what's being prescribed. In fact, 15 people have what's being prescribed for a patient. Then they're filling it at three different locations, possibly because they want to go after the cheapest price, or even the data to know where the cheapest price is located in another location. And then you need prior authorization often for many of it. So then the insurance company has that data. And then you have the data of did they actually take it? Patient information that you could request from the patient. Hey, you filled it, but did you actually take the drug? So then there's that other piece of data. And then there's I mean, we could go on, right? PDMP, the state governments have other data that says, okay, what controlled substance are they filling and where? So it's like the data is everywhere. To me, like that aggregation of data across all of these different locations is why getting the information is so challenging. Is that kind of what you see at Dr. First?
Yeah, I think you nailed it. And I think not only is the data in all of these disparate places, but the level of fidelity of that data, can vary, widely. And I think you're right. We're still not at that magic wand stage where I can actually tell that you took the medication, or even better, that that medication is having the intended effect. But I
Yeah.
will say that we're getting pretty darn close. And we're the accuracy of the data that we are able to provide to our clinicians really gets you, all the way to the finish line in terms of just how adherent is that patient. Did that medication actually leave the pharmacy? Are they splitting their medications and therefore they're not picking up their refills in a timely manner? There's all sorts of insights that we're able to glean here at Dr. First and then provide back to our clinician community.
What's fascinating is we didn't even talk about the data of what could be prescribed and how it should be prescribed. I mean, the new drugs are coming out all the time, and we didn't even talk about that data. It's like you guys have solved this, and other organizations have solved that. Hey, we're going to know what drugs we can add, but like that was the biggest problem initially was like, what drugs are there? What's their dosage? How are they prescribed? It's like, but we didn't even talk about that because I guess we've kind of solved that.
Well, yeah, yes and no. Dr. First does a really good job of this. And what I would call this is what you and I used to call clinical decision support. I think
Yeah.
it now has a fancy name, DSI, or decision support interventions. But the idea of, as a clinician, as a doctor prescriber, it's really hard to keep up with these medications. It's really hard to keep up with their indications, and it's really hard to keep up with the vagaries of dosing, right? Am I starting you on the 2.5 and escalating all the way up to the 10, et cetera, et cetera. And that's where decision support really comes in handy. And that's, we do innovative things like pathways,
Mm.
like pre-sentences for medications, and surfacing this information face up to the prescriber so that they can get it right on the first time. Because guess what? If I get it wrong when I write for it, it's only going to come back to bite me later. I'm going to get a phone call. I'm going to get a fax. My patient's not going to pick up that medication. So I think you're spot on in terms of medication management really starts, at the prescribing level. And, with 25 years in the industry, that's something that we're really proud to have innovated against.
Yeah, it's one thing to know the drug, it's the other to know the drug to drug interactions. All the clinical decision support is, I'm still old school, I guess. I still have the old term. But, it's interesting when you look at that breadth of what's required. To me, it's crazy that someone wants to build it themselves, right? Like, but I think it's like an age-old question that I think we have as health IT companies, EHR companies in particular, when they look at this, medication management, some of them have built it. And so then you have the technical past of, hey, we built it already. So why do we want to scrap it versus, should we buy from someone like Dr. First, and leverage them? But maybe we don't get quite as many customizations because we didn't build it ourselves. It's a classic, IT question. But when I look at, what we just talked about, and then layer on regulatory compliance issues, which are changing all the time, I think it's so interesting to look at, okay, should we build this medication management, e-prescribing, et cetera, ourselves in-house for our solution, or should we outsource it to another organization? I think that's one of the most interesting conversations out there, for an organization to decide. What do you hear when you're talking to different companies? It's funny you said you came from Athena Health. I know they've decided to use Dr. First for a lot of it. We've had him on the program before. They should go check out that episode. But
Yeah.
what do you see on kind of that build versus buy out there?
Yeah, build versus buy is the age-old question. I used to have to wrestle with this in my former life as a CMIO. What I'll say is that as the regulatory landscape gets more complex, as the technology gets more advanced, as new requirements enter the scene, it starts to make sense for a lot of folks to look to someone who has a real expertise in that space, particularly since interoperability and the openness of some of the EHRs has really started to blossom. You can actually get a very bespoke experience in your native EHR while still working with a specialty vendor like Dr. First. And so what we typically see, what you're referring to is that there are some new requirements on the horizon around the e-prescribing standard. NCPDP announced a new version, which we're going to have to be compliant with in a few years. And at some point, a lot of our partners say, you know what? I have other things I need to be focusing on. Why not let someone who's been doing this for 25 years and doing it well, why not let them take over? And so that's how we've been able to, build our base as well as layer in other solutions in this complex world of medication management.
Yeah. And I think you're right that EHRs have evolved to the point where, and even APIs in general have evolved where you can create a really integrated experience for a lot of the solutions out there. I think it takes years to get there to do that right, so that it looks like it's native to the application. I was having a conversation recently at Epic. I went to their UGM. I was talking to one of their leaders and their innovation leaders, and I asked him. I said, "Hey, how do you choose when you implement it yourself or when you want to partner with people?" And he, especially talking about AI in this conversation. And I was like, yeah, because in many cases you have 100 AI projects that you're working on, but then with ambient clinical voice, AI medical scribes, you've decided, hey, we're not going to do that. We're going to work with partners. And I was like, how do you make that decision, right? Because it's kind of that same decision. Should we build it ourselves, the medication management, or should we outsource? And he said something really interesting. He's like, John, the maturity of the product is what really indicates when we should build it ourselves or not. And he's like, in the case of the ambient clinical voice AI medical scribes, those products are really mature. Sure, could we try to catch up with that? Yeah, we could, right? He said, but why should we if we could just integrate that solution? We have enough other things to do. We don't need to do that, right? If someone's already mature and doing it well, then let's just focus on that, and then let's integrate with them because they're already mature, and focus on other things, because EHR vendors, development list is long, every one of them. And so, I think that was an interesting take on when should you build versus when should you buy, is how mature is the application that I can integrate with. That matters a lot to me. So that made sense as I talked to him.
Oh, I think that's spot on. Had they decided to chase down ambient voice, they're behind, right? Depending on which expert you're looking at, anywhere from 3 to maybe even 10 years behind some of these folks who have been working on it and have really been perfecting it. That's exactly the argument that I make around medication management, is doing this for 25 years, active participant in the regulatory scene, in the NCPDP scene, how we're defining these standards, how we're going to adhere to them. You guys have got other stuff to worry about. Let us take this on for you. And not only that, we're so good at it, we're going to innovate against it as well. We're going to
Sure.
find new and better ways to do this because we've been doing it so long, and we are stacked with clinical experts and engineers who really speak this language well.
Yeah, and that's what innovative companies say. They're like, "Oh, you could spend a year or 2 years building what we did, but then you're going to be a year or 2 years behind. We're going to keep going, right?" That's awesome. Well, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and special guest host Dr. Colin Banis. I want to take a moment to thank our sponsor, Dr. First. They put the power of clean, complete medication data within reach of clinicians, integrated directly into your EHR's workflow so they can focus on patient care from prescribing to adherence. When clinicians spend precious time hunting for missing clinical data, it interrupts care and increases the risk of errors. When patients don't take their medications as prescribed, it worsens their conditions and leads to unnecessary complications. Both hurdles can lead to avoidable readmissions and frustrated providers. More than 270 EHR and health IT vendors integrate with Dr. First Solutions to deliver the right information to their clients at the right time. So be sure to go check out drfirst.com. Awesome. Well, Colin, as you look at, forward, and we had you on the program another time, and, I've seen some of your webinars talking about this as well. But talk to me about how specialty medications and prior authorizations are impacting medication management as well.
Yeah, this is a level of complexity that's only growing in recent, I would say recent years, but even recent months. It is accelerating. The rate of new drug discovery, the rate of new drug release, and typically these new drugs are specialty medications, and specialty medications have different, what I would call barriers to entry in
Hmm.
terms of getting our patients to initiate and stay on therapy. And one of the biggest barriers, aside from what we talked about before, which is simply understanding how to use it, it's so new, and how to dose it, and what interactions it has, is how to get it approved.
Hmm.
And that's where the prior authorization argument comes in. And you know, you and I have been doing health IT for quite some time. I'm entering my 25th year almost. Prior authorization was always a bane, but it seems like it is exponentially more complicated and more involved now. And so that is a layer of medication management that is really what I would call a cognitive burden to the clinicians and to the clinical staff. That is not a good use of their time in terms of chasing this stuff down, faxing it, understanding the requirements, et cetera. And so this is another, exploding area for Doctor First to take it by the reins and really become an industry expert and a leader in the prior authorization space, particularly for specialty medications.
It's interesting you say that. I asked a doctor one time, "What if we could do anything for you? What could we do to make your life better?" He said, "Figure out prior auths." He said, "I waste so much time on the phone, calling, waiting, trying to get the medications for my patients. He said, if we could solve that, he said it would make my life so much easier." So, I mean, to your point, that's a big one. And you're right, prior auth is moving so quickly. And I would say, along with prior auth, is denials. Yeah, I don't know if you saw the recent news that one of these health systems decided to stop taking a payer because that payer was denying so many claims at a higher percentage than the other payers that they were working with. And one, it's amazing we have the data to look at that now, and that we're using that data to go to the payers and saying something's off. Something's wrong here. And we're even hearing claims that payers are denying stuff just kind of, hey, let's just deny and see if they reappeal and do the rework. And so, now you look at it from the prior auth perspective. It's like, okay, we see some people doing prior auths and then they aren't even paid for the prior auth. It's kind of messy. And, we see this from the government regulatory agencies. They're saying we need to figure out prior auths. It's a problem. And I think we're going to see some really interesting regulations around it that, help push forward e-prior auths, right? Doing it electronically. But then also, hey, how are you approving this? And are you doing this in a way that is best for the patient? If you're not, then they're going to probably figure out some regulation, some, even penalties for organizations that don't do it. And so, to your point, it's moving quickly. It's the fastest I've ever seen. I've heard, dozens of company come to us saying, yeah, we're going to automate prior auth for you. And, it's like, okay, that's great, but what are the payers going to do? How are you going to do it? It's a complex issue. But now I'm seeing, the government regulation getting behind it, and many of the payers saying, oh, we better figure this out before the government forces us to do something we don't want to do.
Yeah, it's the one word that I think of when trying to understand this process is it's a lack of transparency. I guess that's more than one word, but maybe opaque would be the word.
One idea.
Yeah, well, the doctors don't understand, or the prescribers don't understand the requirements. They don't understand where in the process the particular authorization might sit. Is it pending review? Is it approved? Is it denied? The patients have even less visibility into this. They show up at the pharmacy and realize, oh, this thing hasn't even been initiated yet. You need to come back later when the prescriber has gone through certain hoops. And so, at a minimum, if we could just shed some light on the process in terms of understanding the requirements and understanding, where we are in the process, I think we would get a long way. The other thing that is interesting, and you mentioned, massive amounts of denials, is the role of AI in prior authorization, right? We look to AI, and I think a lot of experts would agree with this, is that we're in an era of clinical AI where we're looking for it to help automate the non-clinical, right? The administrative burden. Help me fill out this form. Help me do a little bit of the intake. Help me write my note, as opposed to the diagnostics and the clinical recommendations, which I do think are coming. So as that administrative AI starts to help on the clinical side, you're almost seeing an arms race where the other side is using AI to help them in terms of processing and even denying a lot of these prior authorizations. So it's an interesting game of tit for tat that really leaves the patient in the middle and leaves them wanting. And that's why I go back to that term of transparency. At a minimum, as a vendor in the space of medication management, let's help provide transparency not only to the clinician but also to the patient.
Yeah. It's kind of sad that we have more visibility on whether our pizza's done than we do whether our prescription's actually approved and filled and
Yep. The
like
pizza tracker, it's, and we're working on it because that is the perfect analogy, right?
it
Prescription
is.
sent, prescription pending, PA, in review, PA approved, patient has picked it up. Let's close that loop and let's let everybody in the system understand the various data points.
Well, I think that is the interesting part about this is that the patient wasn't at the center of this process, right? Like in a lot of ways, we wouldn't do what we did if the patient was at the center. And when I look at this, whether it's value-based care, whether it's ACOs, putting the patient at the center is going to be key. And being able to engage them in the right way and to be able to fill the gaps in care that happen in the populations, I think this really matters. And so, I think in the past we could take them for granted, but I think now when you look at what healthcare organizations need to do and what they're at risk for, those gaps in care that happen in their populations are going to be a problem both for the patient, and they should be doing right for the patient, but also financially for them as an organization. Because if they're not filling the script because it's too complicated a process or they didn't get the prior authorization quick enough, patients are impacted by that, especially with the specialty medications that are very targeted to a specific need. If we don't streamline that medication management process and ensure that the patient could fill that prescription and get the medication they need, well, then there's going to be the downstream effect of your population is going to be more expensive and you're not going to get paid what you could be paid and what you should be paid for taking care of that patient.
Yeah, it's an apropos observation because actually today, I think there was an article from today or yesterday. CMS announced that this year was record payout in ACOs.
Yeah.
This is a record payout in ACOs, and from their point of view, a record savings on the CMS side for those patients who were participating in ACOs. And guess what's one of the biggest things that can move the needle in value-based care? Medication management, right? Medication adherence. I get you on therapy, I keep you on therapy. Guess what? Your clinical outcomes are better, your readmissions are lower. Those star ratings for your plans and for any publicly facing measures, those things are going to go up because, and it seems like one of the most obvious things that we could go tackle, but it's so complex based on what we started this whole conversation with, which is the disparate data and understanding what is my patient being prescribed, what are they really getting filled, et cetera, et cetera. But and that's another area of expertise for Dr. First is the population health and medication adherence, along with that added last mile of patient engagement. Let's get you on therapy, let's keep you on therapy, and all of the good things will follow.
Yeah. And then I think that's the other piece of the data is reporting back how the therapy did, the patient reported outcomes, did they fill the script? All of that information is interesting. But I actually think you're right. I don't think EHR vendors and health IT vendors are focused on this. And I can't really blame them in a massive way because they have so many other fish to fry. There's so many other things, including AI, that they need to embed in, throughout their systems that sometimes things like, oh, how do I engage the patient in their medication management isn't top priority for them. That's been a problem because they have so many other things to do. I think that's the challenge with this is that there's it kind of reminds me when a lot of health IT solutions go to health systems and they're like, hey, we can solve this little problem for you, and the health system's like, dude, have you seen our list?
Yeah.
Like we have 50 other things. Sure. And this person's like, wait, I can save you millions of dollars on this if you do this. And they're like, yeah, but this one will save me hundreds of million, right? Like, so
Yeah.
it's like, yeah, your solution is beneficial, but I've got all these other things to do. I kind of feel that's where EHR vendors, health IT vendors are at is like, yeah, we could do medication management, but we got all this other stuff that we need to focus on.
Yeah, where is the oxygen being consumed? In my former life, I would argue that the regulatory scene was consuming all of the oxygen and
Oh, yeah.
stifling the innovation.
Uh-huh.
Same thing with revenue cycle, right? If you're not getting, no margin, no mission, for example. And so
Yep.
there are things in, what I would call Maslow's hierarchy of needs for a clinic or a health system that just do take priority. But that's where it becomes really incumbent upon guys like us and the folks that you were speaking of who have these really great solutions to make it as easy as possible, to make it a minimal lift, to make it tightly integrated, and to prove on our end, when we come a knocking, there is a real ROI on this. There is dollars to be saved. This is worth the bottom line as well as the clinical impact. And that's a challenge for all vendors, but it's an important one.
I mean, that's the build versus buy decision right there. But I think what's frustrating as an end user of an EHR is you're like, why can't you just do this simple change to that medication management to improve my life? And the HR vendor, looks at it and says, I want to, but I just can't get to it. Right. So it's, so if they can offload some of that innovation to partners, it allows them to say yes to their customers more often than they would, whereas, when you're an end user, you're like, come on, it seems so simple. And then the end user, what they don't understand is that, hey, they're getting, thousands of those simple requests to
Yeah.
update the software. So I think it's a balance.
Yeah, I think healthcare IT is a cycle, and I think you saw us go from niche systems, bespoke solutions, one-off solutions according to need or specialty, all the way to the monolithic EHR where folks said, okay, everything's got to be, I don't care if this is better. If my vendor does it, we're going to use that one because it's easier, the integration is easier, et cetera. And now it's starting to shift again to because of the openness, because of the improved interoperability and APIs, we're getting back to, all right, there's actually room for both. And where something my core EHR doesn't do well, there is an ample argument to evaluate someone who is a specialist in that space.
Absolutely. Well, this was a lot of fun, Colin, and thanks everyone for tuning into this episode of Healthcare IT Today. I want to thank Dr. First for sponsoring today's episode. You can learn more about Dr. First and their end-to-end medication management solution at drfirst.com. Find more, and also be sure to check out our show on the programs page at healthcarenowradio.com and share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm John Lynn with special guest host Dr. Colin Bennis. Thanks for listening and have a great week.
Thanks, John.